So good morning, everybody. I'm talking about a study dealing with instant and early rule-out using cardiac troponin and copeptin in low to intermediate risk patients with suspected acute coronary syndrome, which was a prospective randomized multicenter study, and I'm doing this on behalf of the Biomarkers in Cardiology Research Group and also the collaborating investigators which are listed on the slide. So this was a investigator-initiated trial and sponsored by Thermo Fisher, but also by the participating institutions, which you can see here from their logos. Just a few words for the background. The clinical need to instant rule out of AMI and early discharge is based on the fact that we do have an overcrowding of emergency facilities with 10% of patients presenting with chest pain, but only 10% of those having real acute myocardial infarction. So we do an extensive work on patients who do not need specific cardiovascular care. And copeptin is the name of CT pro-vasopressin, which is a marker for vasopressin, a marker of severe hemodynamic stress. And vasopressin increases immediately with acute myocardial infarction. So we found in observational studies that a combination of cardiac troponin and copeptin at presentation has a negative predictive value of 99%. So this was the ideal candidate for this type of study. So this slide summarizes the study design. So we included patients at low to intermediate risk with suspicion of ACS. They must be troponin negative. And then they were randomized in two treatment groups. One is a standard process group with serial troponin measurement, serial ECG on this chest pain unit. And the other group was the experimental group using copeptin in addition to troponin from the first single blood sample. And in copeptin positive patients with a cutoff of 10 picomole per liter, the patients were kept in the hospital and got the same standard process as the other group. And in the negative patients, the physicians were able to discharge the patients immediately into outpatient care. And we had a primary endpoint of MACEs at 30 days. So this is the major result. You can see this in the yellow line, that the standard group has a 30 days MACE rate of 5.5%, and the copeptin group has merely the same event rate of 5.46%. So with respect to the non-inferiority design, you see the absolute difference, which is pretty small, and the one-sided confidence interval of 3.3% means that the 5% non-inferiority margin was not crossed, so it's also statistically significant no inferiority of the new process. If you do a per protocol analysis, you see that it's more in favor of copeptin, having a 5.68% MACE rate in the standard group and a 3.18% MACE rate in the copeptin group. And we did also sensitivity analysis because we have some losses to follow up in this low-risk population. And you can see this in the lower two lines, which shows you that even assuming poor outcome in the losses to follow up or good outcome in the losses to follow up, there's no significant difference between the two groups. With respect to effectiveness, we looked whether we were really able to discharge these patients earlier applying this new strategy. And you can see that in the copeptin group, 66% of patients were directly discharged from the ED, whereas only 12% in the standard group. So finally, I conclude that the new process is safe. Using one single combined troponin and copeptin test at presentation can aid a safe and early discharge process in low to intermediate risk patients presenting with suspicion of ACS. And the new process is also effective because we could discharge 66% versus 12% in the copeptin group, where in the ED. And the tested strategy has a potential to change clinical practice with high patient safety. Thank you very much for your attention.
So we will open for questions now. Up here in the front. Yes, please.
Yeah, Bruce Jansen from Cardiology News. So the blood is drawn. How long does it take, on average, to get the result back?
Well, you mean the result of the copeptin test?
Yes.
This depends a little bit of the individual logistics of the hospital, but it's around 1 hour.
And is copeptin, does it have regulatory approval as a test in Europe?
Yes. Yes, it's CE marked.
It is?
It is.
How about in the US? Do you happen to know?
I'm not sure whether it's already FDA approved in the US. I don't know.
Okay, next question.
Ed Sussman with MedPage Today. You had about 5% of patients in both groups had MACE events after treatment. Was there a difference in the type of MACE that occurred in those two groups?
Well, I mean, the numbers was not exactly the same, but the MACE rate is driven by unplanned PCI, and there are no significant differences between the MACE type. We had no death in the copeptin group.
One final question, and then we will add two more questions.
Good morning, Lucy Turpin, LTC News. Is your concept ready for routine, and will you be using it at the Charité?
Well, we find, I mean, this is the first prospective intervention randomized study on a rule-out process in suspected AMI, and we think that the results are convincing, and so we will do it in the practice, in clinical practice.
Thank you. And our final question.
And can you just say a little bit about the difference between the intention to treat and the protocol analysis? Why was there such a difference given, it's hard, I don't see why they wouldn't everyone get treated as planned.
Well, yes, I mean, this is a process study. That means we test not only the biomarker combination, but we test two different processes. And so part of the process is that the clinician is able to overrule let's say, what the biomarker says. And this means that not every patient assigned to one process gets this treatment. So that's why the intention to treat analysis has a slightly different result as a per protocol analysis, which shows what would happen if you treat like the protocol has prescribed it. And I mean, this is, I think, more a stronger argument for this concept that if you do so, it's better. If you, because the intention to treat analysis is more conservative with respect to the new process.
Well, thank you. On behalf of Professor Huber and myself, I want